Hello. Welcome everyone. Please be seated. Okay. It is my great pleasure and honor to introduce one of the most accomplished cardiologists of our time, Dr. Chandrakant Chavan. Dr. Chandrakant Chavan is a highly accomplished interventional cardiologist and electrophysiologist from Pune with extensive expertise in the management of complex cardiac conditions. He has completed his MBBS, MD in general medicine and DMB in cardiology, along with a fellowship in electrophysiology, making him one of the leading super specialty consultants in his field. Currently, he serves as a consultant at Pune Hospital and Research Center. He has also contributed his expertise as a consultant at Surya Sahedri Hospital, associate consultant at KEM Hospital, and at Bharati Hospital and Deemed University, Pune. Dr. Chavan's clinical expertise spans a wide range of advanced cardiac procedures, including coronary angiography, CT coronary angiography, angioplasty, coronary interventions, EP studies, RF ablation, device closure, balloon mitral valvoplasty, and implantation therapies. He is also the recipient of the D.P. Basu Award. Beyond his clinical work, Dr. Chavan is a passionate researcher and academia. He has authored numerous peer-reviewed research articles contributing significantly to the scientific literature in cardiology. His research spans a wide range of topics including hypertrophic cardiomyopathy, device therapy, atrial fibrillation, coronary artery disease, and genetic studies on cardiovascular disorders in the Indian population. His work has been published in reputed journals such as Indian Heart Journal, Annals of Internal Medicine, Indian Pacing and Electrophysiology Journal, and many others. His 2007 publication on hypocalcemia as a cause of reversible cardiomyopathy with ventricular tachycardia remains widely cited. With his strong blend of clinical excellence, academic contributions, and commitment to patient care, Dr. Chandrakant Chavan continues to make a meaningful impact in the field of cardiology. With this, we begin the day with Lecture 1 of Dr. Chandrakant Chavan Sir on Introduction to Hypertrophic Cardiomyopathy, Clinical Features of Hypertrophic Cardiomyopathy, and its Symptoms. Sir, I request you to please come on the dais.
Hello. Yes. Pointer. Madla
है next. Okay.
Good morning, all of you. I think I thank Dr. Varsha for inviting me for this talk and interacting with you all. I think today's our agenda is mainly to focus on hypertrophic cardiomyopathy. I will be mainly focusing on clinical profile and how do you investigate hypertrophic cardiomyopathy. I'll try to keep it simple, and by the end of talk I hope all of you are able to understand and at least know what the disease is exactly and what it causes in society and why we should know so much about it. I think all of you must have heard and seen sometimes on TV channels or when the games are going on, someone just collapses and falls down. And cardiac resuscitation is given. Usually, sports experts or sports medical personnel are available on the most of the international matches. Especially, I think the deaths which occurred on a football ground when it's a vigorous exercise activity which is there, and someone collapses and one is not able to be resuscitated out of it. and person dies. So it's a sudden cardiac arrest. So, and it's in a young individual. So it's very common disease, hypertrophic cardiomyopathy, which causes this sudden cardiac death. And this is the commonest thing that you see, that usually in a sports person having sudden cardiac arrest and not able to be resuscitated, and you are not able to save a person. This is mainly because of the problem with the heart muscle in these patients, that they have sudden cardiac arrest in this. So this is what actually elicited why we should go ahead more details of finding out this hypertrophic cardiomyopathy and how do you treat it. Normally all of you know we have 4 chambers in the heart. There is a left ventricle, there is a right ventricle, there is a left atrium, and there is a right atrium. This disease affects muscles of the heart commonly, and this affection of the muscle is peculiar in the term that only the interventricular septum is thickened. Interventricular, that means this is the right ventricle, this is the left ventricle. So in between 2 ventricles there is a septum. This is called as a interventricular septum, and this interventricular septum is hypertrophied in hypertrophic cardiomyopathy. That is why the muscle is hypertrophied. Just all of you must have, that once you exercise too much, what happens? The muscle mass increases. You start getting good bounces on biceps and whichever muscle you are exercising. So similarly, this muscle gets hypertrophied in hypertrophic cardiomyopathy. Mind you, all of you must be feeling that once muscle is hypertrophied, it is good, no? It's going to function, it is better for a person, no? What do you feel? Is it good or no? It is good to certain extent, but beyond certain extent it is not good, because it causes more of some bad changes in the heart, and it disturbs the ventricular functioning of the left ventricle, and sometimes it leads to heart failure and arrhythmias, which are really worrisome for us, and that can cause a problem in a human. So although it is hypertrophied heart will obviously contract vigorously. So it's a hypercontractile ventricle. Normally all of you must have heard a terminology called as a ejection fraction. That means amount of blood that left ventricle ejects out of it into the aorta, into the circulatory system, so that we can survive. So that ejection fraction is commonly 60%. So if there is 100 ml of blood coming to the left ventricle, it only throws out 60%. 40% remains in the ventricle. It doesn't, the left ventricular bag does not get emptied completely. Okay, if it gets emptied completely, what will happen? We will not survive. Remember that. So what you need is, there is some amount, it has its shape, it has to maintain its shape, turgor, and volume. So some amount of blood is always left out in the ventricle. Usually it is 40%, and 60% goes out. Whereas in hypertrophic cardiomyopathy, because of the hypercontractile ventricle, what happens is good amount of blood is thrown out. So ejection fraction is very good in these patients. It may be sometimes more than 60%. It can be 80% or so. So, but more than that, the problem that comes is because I think all of you know that those who are well built and good musculature is there, they have limited movements. You must have seen, they are not very good dancers. For a flexible person who is really very good flexible person can dance very well. His muscles are flexible. They can take whatever shape you want, so they can do any range of movement that is possible. Whereas the one who is very muscular, bodybuilder, he cannot do all the steps. He has some restriction because his muscles cannot work to that extent. They cannot stretch to that extent. So same problem occurs when you have a hypertrophy also. When you have a hypertrophy in the left ventricle, it cannot get dilated. It cannot accommodate more blood. It becomes more stiff. It has a limitation for dilatation. So what is the work of left ventricle? Always take blood from left atrium, get bigger in size, and then throw out the blood, 60% of the blood. But if it does not accommodate blood properly, what will happen? The blood will not come from left atrium into the left ventricle. So left atrial pressure will start rising up. left atrial pressure will go higher. And once left atrial pressure goes high, left atrium has to work very hard, too much contractility with too much force, and pressure inside the left atrium increases. Now, see, left atrium has limitation. Left atrium is very thin structure. You can see here, left atrial wall is this thin. It is not very thick. This is the left ventricular thickness, whereas left atrial thickness is not that great. It is about 3 to 4 millimeter, not beyond that. And actually posterior wall of the left atrium is very thin. It may be just hardly 2 mm thickness, not beyond that. So if left atrium cannot accommodate all this pressure or all these things, what will happen? All the blood will be, or all the pressure will be transmitted back again into pulmonary veins. I hope all of you are aware of the anatomy of the heart. If anyone is not, you can let me know. I can just explain you in the brief that also. Everyone is comfortable with that? Okay. So all the pressure goes back into the left atrium. From left atrium into pulmonary veins. So pulmonary veins pressure increases, and that pressure is again transmitted back through the pulmonary capillaries into pulmonary artery. So pulmonary artery pressure also increases. That pulmonary artery pressure will again come back onto the right ventricle and right atrium, and even right ventricular pressures will also increase subsequently. So as the disease progresses or as the stiffness progresses, all these things keep on happening in the heart, and finally what happens is then heart failure. So heart has some limitation to increase the pulmonary artery pressure or right ventricular pressure. Beyond certain limit it will fail, it will not function, and then heart failure results. So this is a classical change that occurs when someone has hypertrophic cardiomyopathy. So progressive heart failure is one of the presentation for hypertrophic cardiomyopathy. It means slowly as the ventricular thickness keeps on, muscle starts getting hypertrophied, these changes are going to keep on happening in the heart, and one is going to get symptoms. Now whenever left atrium gets hypertrophied, what happens is the left atrial size also increases. Left atrial size increases, it stretches. You must have seen when someone is exercising too much, what happens on the skin? There are striae. You must have seen there is skin, the subacute fat keeps on breaking, and there is some kind of fibrosis. You start seeing the marks on the below the skin. That is all mainly because of the breaking of some tissues there, no? So that leads to bleeding, and then again the scar formation there. So similarly, when you have left atrium which is getting hypertrophied, there is going to be a fibrofatty tissue in between, and that fibrofatty tissue gives away, and there is a scarring that starts coming in. So once the scar comes over there, the electrical wiring, electrical system of the heart also gets affected, and that leads to some kind of short circuits in the left atrium. The wavelets of current will start rotating around the scar, and that leads to increase currents in the heart and increase different kind of circuits in the heart, and results in atrial fibrillation or atrial arrhythmia. So commonest arrhythmia that occurs because of the hypertrophic cardiomyopathy is a left atrial arrhythmia. Okay, so this is another presentation of the hypertrophic cardiomyopathy, that someone may come with the atrial fibrillation. Now one more thing that you have to see in hypertrophic cardiomyopathy is, once atrial fibrillation develops, what happens is, normally whenever the normal cardiac cycle is there, the current starts in SA node, it comes to AV node, and then goes down onto both the ventricles. But when you have atrial fibrillation, the atrial contraction is lost. See, when the ventricle gets filled up, atrium has to contract and fill up the ventricle. Ventricle gets filled by two mechanisms. I will just tell you in brief. There are two mechanisms by which ventricle fills in each cardiac cycle. The first half of the, usually first half to 1/3 of the cardiac cycle, is because of the elastic recoil. That means the ventricle just sucks the blood inside from the left atrium. So it's a passive phenomena. There is no atrial contraction at that time. Then there is one more phenomena, which is diastasis. So in which the blood just keeps on flowing without any issues. Once with that, what happens is the left ventricular pressure will start going up. Now the last 1/3 of the diastole comes. That is the time when the pressure in the left ventricle and left atrium is same. So what you require now, left atrium has to overcome this pressure. So left atrium then contracts and then pushes the blood inside. What will happen if the AF is there, atrial fibrillation is there, then what will happen? Once atrial fibrillation is there, atrium cannot contract strongly because it is just moving like this, it is fibrillating. This movement is lost. See, this contraction is lost, instead it just fibrillates. It beats at 300 to 600 beats per minute. That is a rate which is reported with atrial fibrillation. So it cannot contract at that time. So atrial contraction is lost and no blood can go down. So usually atrial contraction contributes to about 25% of the ventricular filling. And in hypertrophic cardiomyopathy, when you have stiff ventricle, it may rise to 40%. And this 40% atrial contraction is lost when AF develops. So heart will not get that 40% blood for each cardiac cycle. So what will happen? Automatically heart will fail. It is a congestive heart failure symptoms will, the phenomena will start with the back pressures in this condition. So you understand. So atrial fibrillation, arrhythmia as a presentation for this clinical situation. At the same time, it causes congestive heart failure also in patients. So two abnormalities, two things are precipitated by atrial fibrillation in these patients. Whenever atrial fibrillation occurs, one more thing occurs with this hypertrophic cardiomyopathy. When it fibrillates, the blood stays inside. It cannot empty. So there is a stasis of blood. Blood gets stagnated in that chamber. So whenever blood gets stagnated, what happens? It clots. All of you know, no? Blood, if falls down somewhere, it will clot. It will not do anything ahead. So same thing happens. There is something called as a left atrial appendage over here. Left atrial appendage has a very low velocity of blood flow. So if atrial fibrillation occurs, blood flow stagnates over there, and there is a clot formation in this left atrial appendage. And this clot, if gets dislodged, what will happen? It will go into systemic circulation. That means it will go to aorta, from aorta it can go to any part of the body. And what is more worrisome, if it goes to brain, what will happen if it goes to the brain? It will cause stroke, it will cause neurological problem, and then patient may have hemiplegia, hemiparesis and so on. So that is very dangerous. So this is one of the, sometimes patients may present just as a stroke. Hypertrophic cardiomyopathy patient can come to you as a stroke. Now another clinical presentation that one may have is when this hypertrophied ventricle requires more blood. See, when the muscle mass increases, obviously it requires more blood. Okay, but coronary left ventricle is supplied by coronary arteries. Coronary artery to ek hi rehne wala, it's not going to increase in number. You understand? There is going to be only left main and then LAD, left anterior descending artery, and LCX artery. It is not going to multiply. So you have fixed arteries but increased mass. So what will happen? There will be decreased blood flow. Relative phenomena. There is a theory of relativity, you know. With that, you know, you have increased mass and less amount of blood coming. So patient will have symptoms of reduced coronary blood flow. What are those symptoms? Called as angina. That means patient will start getting chest pain. So angina can be a clinical presenting symptom in hypertrophic cardiomyopathy. Okay, so by definition, I think ACC has defined this. When you go back to hypertrophic cardiomyopathy, that slide of heart, this is classically characterized by, there is a hypertrophy of the interventricular septum and small size of the left ventricular cavity. Okay. When an athlete is there, what happens in athletes also have a very good require very good force of contraction because they are exercising. Rhythmic contractions in the heart lead to hypertrophy of the left ventricle, but they require more amount of blood to be ejected. So heart adapts over there, and there also hypertrophy occurs in athlete's heart, but in that this hypertrophy is associated with the bigger size of left ventricular cavity, because they can accommodate more blood inside. Elasticity of the ventricle also is good in these patients, these persons. Whereas in hypertrophic cardiomyopathy, there is a hypertrophy, but the elasticity is lost. It becomes a stiff ventricle, so it is a smaller in cavity. So left ventricular cavity does not increase. So this is a major difference. See, commonest differential diagnosis for hypertrophic cardiomyopathy. Why I am talking this? Because commonest differential heart diagnosis of the heart is athlete's heart. Athlete's heart also have a hypertrophied heart, bigger interventricular septum, bigger posterior wall. However, their left ventricular cavity size is quite big. Okay. So by definition, when you say ACC defines this as disease characterized by thickening of the heart muscle, that is left ventricle, without another identifiable cause. In athlete's heart, you know that person is athletic, that is why his chambers are hypertrophied. If you have obstruction to the left ventricle, what will happen? Left ventricle has to work against resistance. That means if the left ventricular aortic wall gets narrowed down, that is called as a aortic stenosis. If that occurs, valvular aortic stenosis occur, the ventricle will keep on contracting and it will get thickened. But there it is mainly because of the obstruction to the exit of blood from left ventricle. So there is this disease is characterized by thickening of the heart muscle without any other identifiable cause. That means there is no aortic stenosis. Person is not athlete. There is no left ventricular outflow tract obstruction. In such situation only you label this as a HCM, because even the other conditions will have hypertrophy of the left ventricle, but it is not same as hypertrophic cardiomyopathy. It is different. The thickening can obstruct blood flow out of the heart, causing obstructive HCM. Now, what happens because of this thickening is that this can cause obstruction to the outflow, leading to obstructive hypertrophic cardiomyopathy, or lead to impaired filling of the heart, that is diastolic dysfunction, and HCM is caused by genetic mutations affecting the heart muscle protein. So here the cause is different. Here the cause is because of the genetic mutations affecting the heart muscles, leading to abnormal muscle fibers which are hypertrophied, disarrayed, and means there is no proper arrangement of the heart muscles, and hypertrophied heart muscles are there. So that is the main definition. You all should remember this properly. Now, so going back to again this slide. So this hypertrophied septum, as we saw, it can cause obstruction to the left ventricular outflow tract, because whenever the septum gets hypertrophied, it has the left ventricular cavity. You know that below the aortic walls, this aortic wall lies over here, somewhere here. So if this septum gets hypertrophied, blood cannot eject out easily from here. It is going to narrow down the path of blood getting ejected out easily. So it will cause a left ventricular outflow tract obstruction in this. That is called as a obstructive HCM, HOCM. So two terminologies usually are there: hypertrophic cardiomyopathy, which is either obstructive or non-obstructive. Obstructive is whenever you have obstruction to the left ventricle. Now this obstruction will lead to usually formation of gradient between left ventricle and aorta. So if gradient is more than 30 millimeter of mercury, we call it as a obstructive hypertrophic cardiomyopathy. And non-obstructive is you just have a hypertrophied left ventricle, it does not cause any obstruction. It is just hypertrophied but not causing any obstruction. Now why it causes obstruction, I will talk to you. So usually it's a autosomal, as we saw in the definition, it's a autosomal dominant disorder. I think genetic part will be discussed in further lectures, so I'm not going into it. Incidence is about 1 in 500 adults. Yes, male predominance is there. Even in Indian population also, when we see, usually we see the similar kind of incidence, about 2 to 3 per 1000 patients. Sporadic mutations are also known. I have written 11 genes, but I think sir was telling me more than thousands of genes, different genes are identified. Beta myosin heavy chain, troponin I, myosin binding protein C is usually involved. Nowadays, I think more concentration is on genes related to myosin binding protein C, and it may be associated sometimes with Friedreich's ataxia, Fabry's disease, Danon disease, and these are different syndromes which are genetic syndromes, and that there may be association seen. So this is what actually happens whenever you have hypertrophic cardiomyopathy. You can see this is the left atrium, this is the left ventricle, and this is the aorta. So blood comes from left atrium to left ventricle and gets ejected out into the aorta. So this is the IVS, which is hypertrophied. You can see this is hypertrophied septum. So when this hypertrophied septum is there, it does not allow the blood to go out of this ventricle, and then this causes obstruction here. Okay, blood is ejected from left ventricle into aorta, systemic circulation. So this hypertrophied septum does not allow blood to go out, and it causes obstruction over here. Okay, now there are two ways this obstruction occurs. Mainly it is because of see, whenever there is a streaming of blood through the obstructed segment, what happens usually? Suppose you have blood flow which is occurring. If you start narrowing it down, what happens usually? The stream velocity increases. So the blood velocity increases first of all over here. Now whenever this blood velocity increases, because of this causes zone of low pressure on either side of the jet. That itself will suck this mitral apparatus inside more. So this mitral apparatus moves anteriorly. You understand? That is called as a Venturi effect. So I'll just draw and show you. See, whenever you have hypertrophied septum like this, and there is a mitral valve here. So this is a left ventricle, and this is the hypertrophied septum, and this is aorta here. This is the aortic valve. So when blood streams out through this, what happens? It creates a low pressure zone on either side of the jet, and this itself will suck this mitral leaflet inside the LV cavity. So already this is narrowed down. This negative, the pressure which will suck the mitral apparatus towards anterior side towards the interventricular septum will further narrow down the left ventricular outflow tract, and that will increase the gradient further. So that's called as a Venturi effect. You understand? So because of the fall in the pressure on the lower side, there is a further it perpetuates whatever is there already gradient. That gradient further increases, and there is another theory that is being described. Whenever this is thickened, some thickening is there in the other walls also. So this whole thing pulls the mitral apparatus anteriorly. Because of the contraction itself, the septal contraction itself, it will pull the mitral leaflet little anteriorly. That itself will also cause obstruction. So these two findings are supposed to be responsible for causing left ventricular outflow tract obstruction in these patients. So what will happen if LVOT obstruction occurs? Any students are there? I think we'll keep it little interactive so that what will happen because of the obstruction. What do you feel? You can answer. What will happen? The blood does not go out from here. So what will happen? There will be no blood flow going to the brain. So patient will, if blood does not go to brain, what happens? Brain stops working, no? And then patient collapses. So if brain stops working, patient will collapse. There is a decrease in the pressure on the aortic side, so that leads to sudden fall. Okay, that is called as a syncope. As we were talking that some of the athletic games, when we see that person has collapsed on the ground, that is because of the obstruction to the outflow tract that occurs and leads to the sudden fall while playing or while having some games and all that. So one of the important symptom that is there is a syncope. This is called as a syncope. Syncope is what? Sudden loss of consciousness and postural tone, loss of consciousness and loss of postural tone with complete recovery from this event. Okay, person has to fall down, but patient is completely recovered. Then only we call this as a syncope. If there is some problem that is occurring, it is not syncope, then it is something else. In syncope, patient completely recovers back from loss of consciousness. That means you will lose your consciousness. You must have seen some patients. कोणी पाहिले ना चक्कर आलेली, चक्कर येऊन बेशुद्ध पडतात पण परत जागे होतात. तर पूर्ण जागा झालं तरच त्याला आपण सिनकोप म्हणतो युजुअली. So that is what has happened here, what happens in hypertrophic cardiomyopathy also, because of any sudden phenomenon. I will come to that, how that syncope occurs. But because of syncope, one just falls down. But once someone falls down, everything cools down, adrenergic system settles down, and parat mahe this LVOT obstruction settles down, and again there is a regain. Blood flow is regained properly and one gets awake. This is usually transient. So there is a transient sudden loss of consciousness with complete recovery, loss of consciousness and loss of postural tone with complete recovery from the event is syncope. And that syncope occurs in hypertrophic cardiomyopathy. So this, I think let's finish off this syncope part of it, how the clinical presentation occurs in this. Whenever you are exercising faster, what happens? There are three components for syncope usually with hypertrophic cardiomyopathy. One is hypertrophic septum coming into the LVOT outflow and reducing the blood flow. So that is one phenomena. Second is important is what? There is an increase in the heart rate. So what happens? Whenever there is an increase in the heart rate, the diastole starts shortening. You have systole and diastole, all of you know. Systole doesn't change, but diastole starts getting smaller. Whenever diastole gets smaller in size or lesser in size, time, what will happen? Left ventricle will not fill adequately. So, if left ventricle does not fill adequately, what will happen? It will become further small in size. So, it will eject less amount of blood than what it was ejecting before. So that itself will lead to decrease in the stroke volume. The amount of blood coming out of this ventricle is called as a stroke volume. So whenever you have smaller left ventricular cavity, if because of exercise there is an increase in the heart rate, diastole shortens. So diastole shortens, further leads to shortening of lesser filling of left ventricle and further reduction in the stroke volume. So moment stroke volume reduces, again what will happen? One will feel giddiness and then one point comes, then person falls down. So increase in the heart rate extremes, too much fast tachycardia will also cause the same thing there. And it is body's mechanism then, you have something called as some receptors are there in the ventricle, they are called baroreceptors. They get stimulated, they send impulse to the brain and then they will suddenly increase the vagal tone. They send impulses through the vagus and they'll, now enough of tachycardia, just shut down, just stop. So there will be sudden bradycardia. So that sudden bradycardia will also cause sometimes syncope in these patients. Okay. So whenever you have hypertrophied ventricle, these are different mechanisms by which syncope can occur in a hypertrophic cardiomyopathy. Okay. And sometimes the stroke, as what I discussed with you guys, that left atrial clot can goes to the brain and that itself small clots can also cause something like syncope, but there it is there is sometimes neurological problem occurs. So it is not a classical syncope, it's a TIA, what we call as a transient ischemic TI, transient ischemic damage is there to the brain. Okay, it's a transient ischemic attack of the brain. Okay. Sorry. TIA is reversible if it usually TIA is the time given is 24 hours period. TIA neurological deficit recovers in 24 hours. If it persists beyond that, then it is a classical stroke. We define it as a stroke then. So I think all of you understood this. I hope so. Okay. So these are the different mechanisms that are responsible. Now what happens is because this leaflet is pulled anteriorly, So what will happen? There will be a gap in the approximation of mitral valve. So this gap in the approximation of mitral valve will cause leakage through this valve. Whenever the ventricle will contract, some blood will go to the aorta, but because it is not approximated properly, it is pulled anteriorly, there is some gap left. So that causes mitral valve regurgitation. That means blood does not come anteriorly, some blood flow will go back also. You can see that yellow jet which is shown is actually a mitral valve regurgitation in this patient. There is some blood is regurgitated back into the left atrium. So HCM is commonly then associated with both LVOT obstruction and mitral valve regurgitation. Now why I am telling you this? Because the clinical findings of hypertrophic cardiomyopathy are dependent on this phenomena. Whenever you have this LVOT obstruction, it leads to one murmur that is called as the ejection systolic murmur, and because of the regurgitation of blood to this side, it will lead to another murmur in the heart that is called as a mitral regurgitation murmur. So this is usually a ejection systolic murmur, and this is usually a pan-systolic murmur that occurs. So you have both, in hypertrophic cardiomyopathy, you have both ejection systolic as well as pan-systolic murmur in these patients. Okay, both the murmurs are seen. Both are systolic murmur, but one is diamond shaped, the other is like a, it's shh, shh, that is pan-systolic. Shh, shh. These are very finer things which your ear needs to get tuned. One is a diamond shape in which the murmur sound goes up and then comes down. The other is murmur sound is constant. So usually in mitral regurgitation, murmur sound is constant, whereas ejection systolic murmur, the murmur goes up and then comes down. So you need to get tuned to ears to identify these both different types of murmurs clinically by stethoscope to identify whether you are dealing with ejection systolic murmur, and both are common in this situation depending on whatever is predominating. Then other thing that occurs, as I discussed, is a diastolic dysfunction. Diastolic dysfunction, as I said, because of the left diastolic dysfunction means what? Ventricle is not relaxing properly. Diastole is relaxation of the ventricle. All of you know, no? All of you are aware, no? Cardiac cycle. So in that, diastole means ventricle relaxes. But this relaxation itself is not common. Relaxation is an elastic property of left ventricle. Usually this elasticity is very much essential. We always concentrate on contraction, but contraction is not the one which makes you survive. It's a relaxation of the ventricle, which is a negative suction effect. It just relaxes and sucks the blood from left atrium into the left ventricle. That is the one which is responsible for good amount of left ventricular filling. So if that diastolic dysfunction, that means the left ventricular filling gets affected, there will be no, see, it is very obvious, if blood ventricle is not filled properly, it is not going to eject also nicely. You understand? So these ventricles are stiffened, they don't fill up properly, and they have an abnormality in filling. And see, this is not like all or none phenomena. Remember this also. Hey, it doesn't happen in just given, क्षणात होत नाही ही गोष्ट. क्षणात होते, कधी होते ती? क्षणात झाली तर गोष्ट, त्याला हार्ट अटॅकमध्ये पण सेम प्रॉब्लेम येतो. Whenever you have a myocardial infarction, the coronary artery gets occluded and the myocardial blood flow is reduced and muscle is without blood. So it just, the muscles don't contract, they don't relax and they don't contract. So what will happen? There is a diastolic dysfunction again setting in there also. But that is the acute one over there. It just suddenly becomes. That is why you start feeling, जेव्हा हार्ट अटॅक होतो त्यावेळी दोन गोष्टी होतात. एक मध्ये चेस्ट पेन होतं आणि दुसरा दम लागतो. You start feeling breathless. So that is because of the diastolic dysfunction over there. But here this diastolic dysfunction is a chronic phenomena. It doesn't appear in one day. There is a genetic disorder. So there is an abnormal formation of the muscles. There is an abnormal hypertrophied muscles. And as age starts growing from childhood to the adolescence, this hypertrophy starts increasing. The hypertrophy starts growing. The ventricular thickness starts growing up to certain adolescent level. And then the ventricle starts gradually becoming more stiff. So there is a gradual change that is occurring in the ventricle, and it's a gradual phenomena over here. So the symptoms won't come suddenly in hypertrophic cardiomyopathy. They are usually chronic. They will start coming one day. Breathlessness will be chronic. One day you just start feeling breathless when you walk 10 kilometers. But as the hypertrophy keeps on growing up, after 1 year you will start feeling breathless after 8 kilometers. After another 4 years or 6 years, you will start feeling breathless on 6 kilometers. And then the time will come, you will start feeling breathless even with the 2 kilometers. And then you cannot walk 1 kilometer also. And if atrial fibrillation occurs, this may be broken down. If AF occurs in between any time of this cycle, there is a sudden loss of 40% left ventricular filling. So you will suddenly become symptoms on one particular day. Okay. So I think all of you have understood how the disease behaves in hypertrophic cardiomyopathy. I think any questions?
Is there any difference at the
Yes. See, these things what we are talking in hypertrophic cardiomyopathy, usually hypertrophic cardiomyopathy presentation is in a younger individuals. Whereas the things that occur because of the age is after 40 years of age. It is not before 40 years of age. So here the symptoms will start even when you are 14, 15 years old, 10 years, 14 years old. Whereas here the symptom starts after 40 years. So that is the age difference is a significant factor. Our children, common normal children don't feel breathless when they are playing at the age of about 15 or 20 years of age. Whereas hypertrophic cardiomyopathy patient will have symptoms of syncope or breathlessness even at younger age. And some family history of sometimes of sudden cardiac death is there. Some sibling or someone in the family in your close blood relation dies of sudden loss of consciousness and just passes off. So that history is there usually with the. So that is the main difference in the age-related diastolic dysfunction and hypertrophic cardiomyopathy related dysfunction. And another difference that pathologically when you see, when age-related problem is there, there is no fibrosis. There is no disarray of muscles. Here muscles are all disarrayed. They are not properly formed. They are placed haywire. And you must have. No, in age, see the diastolic dysfunction has nothing to do with the ejection. It is a filling, as I said. Ejection fraction is because of the contraction, whereas diastolic dysfunction is because of the filling issue. Two different things. You understand? So ejection has nothing to do with the ejection fraction has nothing to do with the diastolic dysfunction. In the diastolic dysfunction is a phenomena where diastole is a problem. Their ejection fraction may be normal, may be abnormal. Both are possible. But in common individuals, as you are describing, age-related problem, person should not have any issue in ejection of the blood. Their ejection fraction is normal. It's age-related loss of elasticity of the ventricular muscle, which leads to diastolic dysfunction there. Okay. I hope I am clear. There are little more medical terminologies, but I am trying to keep it more simple so that you can understand. Any questions you can always ask. Yes. HCM and asthma. HCM is a genetic disease, so there are some subset of patients who may be associated with asthma, but there is no direct relationship as such between the two of them. HCM does not cause asthma or asthma does not cause HCM. It is just they are associated in some individuals, may be a possibility. I do have some patients who have both the problems. They are very difficult to tackle also. Okay. Okay. So I think this all we have already discussed, the Venturi effect and augmentation of left ventricular outflow tract and mitral regurgitation that is occurring. So as I said, this is usually called as a obstructive hypertrophic cardiomyopathy, where peak gradient between the left ventricle across the left ventricular outflow tract is more than 30 millimeter of mercury at rest, and if it is more than 30 it is called as a obstructive, less than 30 is non-obstructive hypertrophic cardiomyopathy. That means whenever you have hypertrophy of the interventricular septum, always there is going to be increased jet velocity across the LVOT, which is going to cause gradient to you, but that is going to be less than 30 millimeter of mercury. But if it is more than 30, it is called as a obstructive hypertrophic cardiomyopathy. And usually sufficient symptoms, if the peak gradient is more than 40 to 50, there will be a good number of symptoms with that patient. That patient is obviously going to have too much of symptoms being there in this group. Now usually this gradient is not, so what we describe this is as a subvalvular obstruction. See, whenever we describe LVOT obstruction, there are three levels. So if there is a valve here, there is a supravalvular obstruction, there is a valvular obstruction, and there is a subvalvular obstruction. Three LVOT obstructions are described commonly. Now supravalvular obstruction is whenever there is an obstruction above the aortic valve. So that is very rare. It's called as a Williams syndrome, in which aorta is narrowed, or sometimes there is a membrane here. There is a membrane that congenitally gets formed, and that causes a LVOT obstruction. So that is supravalvular. Whereas valvular is if the valve is in problem. So valve can be in problem because of congenital problem. That means valve is not formed properly. Is it okay? मराठीत सांगू तुम्हाला समजलं? नॉर्मली वाल म्हणजे काय असतात, पाकळ्या असतात, कमळाच्या फुलाच्या पाकळ्या असतात ना, तशाच पाकळ्या असतात. त्या पाकळ्या जर व्यवस्थित तयार झाल्या नाहीत तर काय होणार, त्या सगळ्या फ्यूज राहणार. त्या पाकळ्यांनी डिवाइड व्हायला पाहिजे. देयर शुड बी रॅफे इन बिटवीन द वॉल्स, ऑल द रॅफ. इफ दे आर नॉट फॉर्म्ड, instead of that they are all fused, so there will be small hole. The valve, aortic valve ला असे तीन पाकळ्या, there are three leaflets. If they are not, these things are not formed, the valve will not function. Instead it will be fused. This is fused and this is, so there will be small opening remaining out here. So that causes a valvular obstruction. Okay, so it can be congenital, it can be acquired also. Valve can get damaged as the age grows. It can get damaged just like that, degeneration. म्हणजे कॅल्शियम आलं त्याच्यात, आपण खूप कॅल्शियम खाल्लं किंवा इतर काही एज रिलेटेड प्रॉब्लेममुळे डिजनरेशन, दीज थिंग्स कॅन ऑल्सो कॉज LVOT obstruction. Important disease in our country is rheumatic heart disease. Rheumatic disease affects the valves, which leads to rheumatic valvulitis. That means inflammation of the valve, and this inflammation will cause fusion of these valve raphe, and that will also narrow down the left ventricular outflow. So that will also cause aortic stenosis. Then there is a subvalvular. Subvalvular is obstruction below the aortic valve. Now subvalvular obstruction is also again of two types. One is this, that is called as a hypertrophic cardiomyopathy, and other is a fixed. That means there is a subvalvular membrane. So why this is fixed and non-fixed? Subvalvular membrane मध्ये there is a membrane like structure which is there constantly. There is a small aperture here, and there is a membrane which does not allow the ejection of blood out of the left ventricle. Whereas in hypertrophic cardiomyopathy there is no membrane. It is interventricular septum which is thickened and obstructing the outflow tract. But this obstruction is dynamic. That means it is not constant all the time. As I said, whenever heart rate increases, obstruction increases. When heart rate slows down, the obstruction is not there. So it is a dynamic phenomena. It is not constant. Beat to beat it may vary. So it is a dynamic LVOT obstruction. So this dynamicity you should remember, because this is a characteristic of hypertrophic cardiomyopathy. So clinical findings पण काय असणार मग? Dynamic असणार. Clinical findings will also vary. If higher heart rate, different findings. If lower heart rate, different findings. You understand? With exercise, different findings. No exercise, different findings. If you give some drugs, different findings. If you don't give drugs, different findings. That is possible. So that is called as a dynamicity That is a characteristic of hypertrophic cardiomyopathy, because findings are dynamic because of the dynamic pathophysiological changes in the outflow tract. Now, what is this dynamic thing that is happening? Dynamic things again depends on the three factors. One is preload, something called as a, there is something, this is little technical, but try and understand. I'll try to keep it simple so that you understand. There is something called as a preload, and there is something called as a afterload, and other is a inotropicity. So preload is what? The amount of workload that is there in the ventricle before it starts ejection. You understand? And afterload is something which is beyond, means it does not allow the ventricle to empty. So both need to be high in hypertrophic cardiomyopathy not to cause symptoms. It means if preload is also high and afterload is also high, patient will not have any symptoms. Whereas if preload is reduced or afterload is reduced, patient will start getting symptoms. Okay? And inotropicity, as I said, if the contractility increases, what will happen? Contractility increases means heart rate increases, contractility increases, diastole shortens, and patient will start getting symptoms. So increased inotropy will lead to increased symptoms here. You understand? So these three pathophysiological things you should remember. Now what happens in preload? Preload is what the amount of blood that comes to the left ventricle. Before the left ventricle ejection starts, amount of blood, amount of load that is there on the heart. So if it is more, what will happen? Left ventricle will be bigger in size. It will be big in size, you understand? So if it is big in size, what will happen? This distance will increase, no? The septum will be away from the medial wall. So LVOT obstruction will decrease. You understand? So increased preload will decrease the LVOT obstruction. So patient will have less symptoms. You understand? I think, am I clear? Preload is if you have more amount of blood. There is a more amount of blood before pre-ejection cha agodar. Preload. So before ejection, if you have ventricle which is very nicely filled, interventricular septum and this distance is more. So it is separated from each other. So if it is separated, obviously there will be less obstruction. If it is very close, that means if the left ventricular size is less, if preload is less, what will happen? The cavity will be shortening and IVS will come close to the mitral wall here, and that will cause increased obstruction. You understand? So less preload, more obstruction, more preload, less obstruction. You understand? So any drugs if you give to the patient which cause decrease in preload will increase the LVOT obstruction. So usually preload kashani kami hota. Why? One is dehydration. Commonest thing is dehydration. If you don't drink good amount of water, blood volume will be less. Obviously preload will be less. If diuretics म्हणजे urine ला जास्त होतात असे drugs जर दिले, that also decreases the preload and that will cause the symptoms in this patient. So hydration is very important in hypertrophic cardiomyopathy patient. Hypertrophic cardiomyopathy patients will usually result in syncope when they are dehydrated. So what happens when you play excess? What will happen? If you play in excess, what happens? Blood volume will go down, na? Because of sweating. What is going to happen? So preload कमी होतं म्हणून syncope येते खेळताना. You understand? Mechanisms are very simple to understand. If you know the physiology properly, that is the commonest thing that happens because of the sweating itself. You are going to have less blood volume. So preload is going to be less and patient will have syncope. Now afterload. Afterload is what? It is the amount of resistance which is offered from aorta side. From aorta side. If that is more, म्हणजे लेफ्ट वेंट्रिकल इजेक्ट करताना इकडे जर प्रेशर जास्त असेल, एओर्टामध्ये जास्त असेल तर काय होणार? ऑटोमॅटिकली लेफ्ट वेंट्रिकलला रेजिस्टन्स असणार टू एम्प्टी. So that will also increase the size. So if it is afterload is high, then also there will be less symptoms. Okay. If afterload is less, when afterload is less, usually when there is a significant peripheral vasodilatation किंवा सिस्टमिक प्रेशर कमी असेल, फॉल्स डाऊन, सिस्टमिक प्रेशर म्हणजे आपलं ब्लड प्रेशर जे आहे, इफ इट फॉल्स डाऊन, व्हॉट विल हॅपन, एल व्ही आणि याच्यामध्ये ग्रेडियंट तयार होणार अँड देन देर विल बी सिन्को. सो मोर ब्लड प्रेशर, हायर द ब्लड प्रेशर, better in HCM. It doesn't mean you should keep it too high, okay. But if afterload is high, it is better for HCM patient not to cause syncope. You understand? So usually again what happens when you exercise? When you exercise, there is a significant amount of blood flow going to the peripheries because your muscles are working, your all musculature is working. So there is an increased blood flow to the muscles. There is a peripheral vasodilatation in the muscles. So there is a increased blood flow going and there is a fall in vascular resistance. Peripheral vascular resistance आहे तो कमी होतो. So that leads to decreased afterload. That means it is a mechanism by nature to empty the blood faster because you want more blood to go to the muscles. So you want more blood to get sucked inside the muscles. So obviously vessels are going to get vasodilated. So that itself will again increase the gradient and cause syncope. You understand? So decreased afterload will cause more syncope, increased afterload will cause less syncope. So this is the pathophysiology, means pathology and physiology behind the cause for syncope in hypertrophic cardiomyopathy following exercise and dehydration. I hope I am clear, no? Is it well understood or no, this thing? Okay. Now, hypertrophic cardiomyopathy is classically characterized by hypertrophy of the basal septum usually. This is seen in almost 70% of the patients. That is why it is called as a asymmetric hypertrophic cardiomyopathy. But everyone does not have this. Okay, sometimes have just basal septum. It is an asymmetrical septal hypertrophy of the septum and anterior wall usually. Whereas just septum can be hypertrophied in about 15 to 20%. There is no anterior wall hypertrophy, only septum is hypertrophied in them. Anterior wall muscle is not involved. Concentric hypertrophy is involving whole of the ventricle, diffuse. The whole ventricle is hypertrophied. You can see this is IVS and this is posterior wall. Both are hypertrophied in this situation. There is one variety which is called as a apical. So only apex is hypertrophied. The hypertrophy is restricted to the apex only. This is in the 2% of patients. This is commonly, it is described as a Yamaguchi's disease. Japanese person has described this and it is seen in about 2% of the patients. It is even seen in India also. Only 2% of the individuals can be affected. So these are all different types of, morphological types of hypertrophic cardiomyopathy. This is a normal left ventricle. This is a sigmoid interventricular septum. This is a reverse septum. This is a mid ventricle. That means you have hypertrophy here, and there is an obstruction in the mid cavity also. So another level of obstruction. Okay, mid cavity and LVOT. Two obstructions will be there in these patients. There will be problem with the filling and emptying from here also and here also. Then there is a apical hypertrophy. This is a apical hypertrophy variant, and concentric is all over the ventricle is hypertrophied. This concentric hypertrophy is commonly seen with aortic stenosis, hypertension, or supravalvular obstructions. So there is a uniform hypertrophy of the ventricles. So as we described these two basic phenotypes, obstructive and non-obstructive. So there will be obstruction to the left ventricular outflow tract. Usually gradient is about 30. If it provocation test, that means as I described, you have to do sometimes to unreveal the hypertrophic cardiomyopathy obstruction, you may have to do some provocating test like reducing the preload or reducing the afterload. That is usually done by various maneuvers. Normal simple maneuvers are Valsalva maneuver, or you can give drugs which cause the reduction in preload and reduction in the afterload. I think I am not going into the details of that. So clinical features as we described, Maximum patients are asymptomatic. 95% of the patients are asymptomatic. So we are doing all these things only for 5% of the individuals. But that 5% individual number is also more, because it causes sudden cardiac death. And it can be prevented. Now we know that we have measures which can be taken to prevent these sudden cardiac death, and these individuals can have a normal life. So commonest symptom is breathlessness. As I said, when they start getting developed chronic heart failure, patient will start getting breathlessness. Then they can have angina. Angina is again because of the two problems. One, as I said, is because of the increased muscle mass, so there is a mismatch. Second is a microvascular angina. That means the small vessels also get affected, and that can cause microvascular angina. The next symptom is syncope, that sudden loss of consciousness. Then sometimes the patient may just come with, it is broad dead, sudden cardiac death. You do pathological postmortem, and then you find there is a hypertrophic cardiomyopathy in this patient because of which the death has occurred. Signs is something that you elicit. Symptoms are something that patient has come to you with the problem. All of you are aware this, no? There are two things this describes: symptoms and signs. Symptoms is a complaint which patient comes to you with. That means chest pain, giddiness, fall. This is all breathlessness. This is all told by patient. Whereas signs are things which are observed by a doctor or a clinical physician. So we have jerky carotid pulse. That means carotid pulse is bispherians. There are two pulses which are seen. One is because of the initial LV contraction, and then second contraction occurs because of the outflow tract obstruction. So last half of the systole is also divided into first 2/3 and last 1/3. So first 2/3 gives you one pulse stroke, and second is because of the outflow tract contraction. So obstruction is overcome, and there is one more pulse. So bispherians pulse is there. Pulse has got two peaks. The systole has got two peaks. One is because of the left ventricular contraction, and second is because of the overcoming of this obstruction. Whenever you have obstructive cardiomyopathy, okay. Non-obstructive will have only one peak, whereas obstructive will have two peaks. That is called as the pulsus bispherians. Sometimes patient may have low blood pressure, and normal pressures also are common, and narrow pulse pressure. The pulse, that means systolic and diastolic pressure difference is narrow in these patients. Then this is what the classical, I said no, pulsus bispherians. There are two peaks. One is because of the left ventricular contraction, other is because of the outflow tract contraction. And this is what the murmur which I described. In systole you see this murmur. This is a diamond shaped murmur. This is initially there is a peak, and then following it is like this. Whereas pan-systolic murmur is just like the MR murmur. This murmur is like this. Okay. This is the first heart sound, and this is the second heart sound. So this murmur is uniform here. Whereas crescendo murmur is like this. So you will have like this, it is diamond shaped. So there is a rise and then fall. So that is regarding the murmurs. I think you can just be aware of these findings. They are little clinical findings. I don't think as they are more useful for you, because you need an expertise to understand these murmurs also. Then there is something called as a broken bro brown valve phenomena. So whenever there is a ectopic, there is sudden increase in the gradient in the next beat. See, normally this is the gradient that you see, but whenever ventricular ectopic comes, suddenly there is a rise in the gradient here. There is a fall in the pulse pressure here. This pulse wave is normally like this. Suddenly it gets blunted. You can see this is blunted pulse wave here. So there is increase in this distance. VPC causing increase in this is classical sign of hypertrophic cardiomyopathy. This is usually described as a broken brown valve marrow sign in clinical findings. Can you get my bag, because charging is, I need a charge. Then there's, because see ventricle has got then two muscles strongly to contract. So one is this apex that contracts, and at the end this septum will also contract, the septal part will also contract. So apex beat, usually apex impulse which we feel at the apex will be of double. For each systole, for each beat there will be two contractions seen. So it's called as a double apical impulse. You will have contraction of this is also felt, and then the contraction of this is also felt. So you will have double beat. Sometimes you can see triple beat also. Why triple beat? One is this, second is this, and third, as I said, left atrium also contracts very strongly. So this left atrial contraction is also felt after that. So it is called as a triple apical impulse in that case. So you may have both the things possible. That pin is not belonging to. Okay, so that is another thing that you can see. Sometimes you may have murmur which is felt. The murmurs which I described, there are these two murmurs, they can be felt, which is called as a systolic thrill. And JVP is normal usually because it's jugular venous pulse is jugular vein, it is on the right side. So usually you may not get any findings related to jugular venous pulse. So first heart sound is normal usually, second heart sound sometimes may be split, S4, S3 may be present, and these are the two murmurs which are usually seen. So I am not going into the details now. This already we have described Venturi effect and generation of murmurs in this. Now going to this is something called as a dynamic maneuvers. Valsalva maneuver is something, Valsalva maneuver is you blow out when you close your nostrils forcefully. That is usually called as a Valsalva maneuver, means against closed glottis you have to blow out. So there is an increase in the intra-abdominal pressure and decreased venous return occurs. So this is to elicit the findings of hypertrophic cardiomyopathy. This is all why Valsalva maneuver is done, again to decrease or increase the preload or increase or decrease the afterload. So this maneuver is used to diagnose. See, in olden days you never had a 2D echo. You know, no, there was no echo. Echo came in 1980s, and so before that also hypertrophic cardiomyopathy was diagnosed. So how it was diagnosed? It was diagnosed by doing this maneuver and listening to the patient's heart. And now also we do diagnose. Before echo is done, we auscultate. No, that time we do understand these findings and diagnose in a patient whether patient has hypertrophic cardiomyopathy or no. So this Valsalva maneuver is usually done to elicit the findings of hypertrophic cardiomyopathy. Do you want me to go in details of this? Because this is a little more going to be tough to understand. I think now the next part of my talk was how do you diagnose this now. So I think once you do the clinical examination, all of you start knowing that we are suspecting hypertrophic cardiomyopathy. If you are getting these findings, dynamic maneuvers are there, someone who has come to you with breathlessness, chest pain, and one episode of syncope is there, and you ask patient, then patient says, हाँ माझा काका मामा किंवा मामा होता तो एक लहानपणीच गेलेला, त्याला 10 वर्षाचा गेला होता आणि मग तो खेळायला गेला आणि सडनली पडला किंवा तो पाण्यात विहिरीत उडी मारली आणि गेला. म्हणजे you suspect then sudden death आहे इथे. There is a sudden, see what happens when you just suddenly jump in water, what will happen? You will be fearful. And what will happen when you get fearful? Your heart rate will increase. So heart rate increase झाला की काय होतं HCM मध्ये LVOT obstruction वाढतं आणि LVOT obstruction वाढलं की काय होणार, आपण बेशुद्ध पडणार. आता तू पाण्यात उडी मारली आणि पाण्यात जाऊन बेशुद्ध पडला तर काय होणार, संपलं तिथेच सगळं. सो यू अंडरस्टँड. सो पाण्यात जाऊन लोक जातात म्हणजे आपण इतक्या कॅज्युअली घेतो तो विषय. इट इज नॉट दॅट कॅज्युअल. You have to suspect. Unless you suspect, you won't diagnose. See, this many a times for hypertrophic cardiomyopathy, you really need a suspicion to diagnose it. I was talking to sir also. Many patients don't tell anything. Even if they have family history, they won't tell you because it may be आपल्या social taboo for us. नाही कशाला उगीच सांगायचं आपल्याकडे हा आजार आहे. But if you diagnose, you have a treatment now. You can be well. I think that has to be understood first. Instead of thinking that it is a social taboo, if you treat it nicely, or I think all of you must be aware of AICD, automatic, implantable cardioverter defibrillator, which I implant to the patients. So that defibrillator, if it is placed inside the heart, these patients will not have sudden cardiac arrest. These patients will not die. You understand? So there is a treatment for it. These patients can be cured, and if you tell them how to carry out your usual life, these patients can be made to survive also. You can, if dehydration is prevented, obviously he will not die then, no? So it's a simple thing. Actually आपल्याला वाटतं काय त्यात तेव्हा पाणी प्यायला सांगतात खूप डॉक्टर. मी तर रोज पाणी पितो. But which moment is going to cause you sudden cardiac death, you don't know. So you have to be hydrated all the time. That is more important. You understand? And some patients may have a problem of hydration. That means water retention may be problem in some individuals, and that patient gets hypertrophic cardiomyopathy. If he has what will happen? He is more prone for recurrent syncope. त्याला सारखंच होणार syncope. कारण काही डायुरेटिक किंवा दुसऱ्या काही आजारासाठी डायुरेटिक घेत असेल एखादा माणूस. If you are giving drugs which cause increased urine because of some other kidney stone झालाय, किडनी स्टोन साफ करायचा आहे, मग तुम्ही काय करणार पेशंटला? डायुरेटिक देणार. मग डायुरेटिक दिलं की there will be diuresis and decrease blood volume. So patient will have syncope which is going to get precipitated. So at this time you have to take special precautions. If HCM is there, you have to tell that patient that you take diuretics, but they have to be controlled. You need to have good hydration. If you are normally drinking 2 liters of water, if you are taking you drink 4 liters or you drink 6 liters of water in a day. So that advice has to be given, and it is all preventable. So that is why we should know about this sudden hypertrophic cardiomyopathy. Now, once you suspect, the previous, I think one of the gold standard tests that is there in cardiology is electrocardiogram. Standard 12-lead ECG is done to commonly diagnose and screen these patients of hypertrophic cardiomyopathy. So 25% may have no symptoms with normal ECG. So some of the patients may just show that they have. Can you pick up and tell to call later or take a message? Some of the patients may have no symptoms and the ECG may also be normal. There will be no findings, no change in the ECG that occurs in 25% of the patients. Commonest finding that you see is change in the ECG because of the left ventricular hypertrophy. So left ventricular hypertrophy will make your ECG abnormal. So what will you see on ECG is a left ventricular force. So I will show you the ECG, how left ventricular force is seen on ECG. And then there may be sometimes deep Q waves in inferior and lateral leads because of the septal hypertrophy, left atrial enlargement. There is something called as the left atrial hemiblock, LBBB, left bundle branch block, sometimes VPCs and poor ROA progression, pre-excitation, and it is associated with one syndrome called as a Wolff-Parkinson-White syndrome, that is WPW syndrome. And sometimes there may be VT on, that means different arrhythmias on monitoring. So normally ECG is seen like this. So left ventricular hypertrophy, usually this R on ECG, all of you know a bit about ECG, or these students are saying yes. You know? Can you describe me in brief all the waves? Just name the waves. Say loudly so that everyone can hear. You are telling something, no? Bolo, quick. हाँ, PQ,
PQRS.
हाँ, loud, tell loudly so that everyone can hear.
PQ, then R.
And
Then
there is a P, Q, R, S and T. These are the common waves which are described on 12 lead ECG. Now P wave is one which occurs usually because of the left atrium, okay, and QRS is because of the left ventricle and right ventricle, okay. So P is commonly because of the atrial problems, I mean it represents atrial potentials on the ECG, whereas QRS is one which represents the ventricular potentials, that is both left and right ventricle. Now positive wave, that is P wave, is because of the atrial systole, that means there is a depolarization. See, it's a electrical phenomena, ECG. So there is a depolarization and then repolarization. Depolarization is current is thrown, and repolarization is current comes back to the normal potential again back. So depolarization wave is a P wave for atrium, whereas QRS is a depolarization wave for both the ventricles, left ventricle as well as right ventricle. So this QRS usually represents the depolarization of both the ventricles. Now R wave is commonly due to the left ventricular depolarization, because you saw the previous cartoon, हार्टचं कार्टून बघितलं ना, त्याच्यात काय होतं, लेफ्ट ventricle is more thick than the right ventricle, so depolarization will be more on the left ventricle. So more changes on ECG will be seen because of the left ventricular depolarization, and less changes will be because of the right ventricular depolarization. So prominent force that you see is because of the left ventricle. You understand? See, if you have two currents, एक खूप कमी मसल मास आहे आणि एक जास्त मसल मास आहे, तर जास्त wherever there is a more muscle mass, you will see the force of current going more rapidly on that side. So R wave is because of the left ventricle representation. You understand? So R wave, if septum is hypertrophied, it is a part of, consider as a part of mainly left ventricle. Left ventricular anterior wall and septum is hypertrophied. So left ventricular force will be tall. So you will have R wave which is prominent. Okay. Normally this R wave is not taller than 15 millimeter. That means you will have three small, this you can see each small box is 5 millimeter. So it will be usually here, up to R wave is usually here, but it is more than that. You can see tall. So that is a sign of left ventricular hypertrophy. So tall R waves will be seen on ECG, one finding ECG, a simple finding to remember. Then lead V1 is normally having small r and big S, but here you can see R wave is very tall. R wave normally is only 1 millimeter of maximum 3 millimeter in V1. Now here it is how much? 5 and another 3, so 8 millimeter. So tall R in V1, R in V1 represents a septal activation. Interventricular septum is activated because of the, which is represented by V1. So septal hypertrophy is prominently seen over here. Okay. Then again, as I said, left atrium is also hypertrophied because of increased force of contraction. So you will see left atrial hypertrophy also. So you will see broad P waves. Broad P waves, tall P waves will be seen in this. So I think just remember that ECG findings are something that will tell you whether you are dealing with hypertrophy or no. Another thing that occurs is during repolarization. What happens is repolarization is also very strong. So you will see this is P, this is QRS and this is a T wave. So T wave is also very deep. You can see the previous ECG had T waves, they are very small, no, positive T waves. Whereas this ECG shows deep symmetrical T waves. So this is also a classical finding of hypertrophic cardiomyopathy. Okay. This is very characteristic in hypertrophic cardiomyopathy. I think just remember that these different things are available. I will try to show you more pictures now so that you get a little worried, little understanding of. So this is mainly regarding ECG. Then we have echo. 2D echo is something, that when came, one started understanding really actually what is happening with the hypertrophic cardiomyopathy patients. Previously, I also remember when I was also student, echo was not, echo was available, and the studies had just started coming up, and more of M mode studies were available. There was no live 2D echo was just introduced into the practice, but there were no guidelines related to live 2D echo were formed at that time. More of M mode findings were there. M mode is you cut the heart. See, if this is the heart, M mode is you cut in this section, and that you see the representation on the. So I will show you M mode. This is the M mode. You can see this is the cursor. This is the 2D echo that shows the left ventricle. All of you can understand this is the left ventricle here. That is being cut like this. So once it is cut in that plane, you can see this is the RV anterior wall. This is the RV cavity. This is the interventricular septum. This is the left ventricle, and this is the posterior wall. So in one plane, you are cutting the image in one plane, in this plane. I will go back and again show you. If you put a cursor like this here, this is the left ventricle, this is the aorta, and this is the left atrium. You saw the previous diagrammatic movement, no? Similar, this is the same picture like that. So you have LVOT over here. This is the interventricular septum. Okay? And you can see this interventricular septum is very thick. Normally it is only limited from here to here, this much. It is double. So it must be at least 20 millimeter now. Normally it is only 10 millimeter like this. And you can see there is some dot which is seen, some light shadow is seen. It is not uniform. So that means there is a disarray. Muscle fibers are not nicely, uniformly organized over here. They are all haywire. Paijil dase, kase, ikade tikade. So that is a groundless appearance. We called it as a groundless appearance on echo of the interventricular septum. And this is the LVOT. Now there is no obstruction over here. There is no turbulence in the color. So there is no LVOT obstruction. It is a non-obstructive hypertrophic cardiomyopathy which is seen on 2D echo. I think all of you understood. This echo is understood. Just a live picture which is showing 2D echo. And this is the left ventricle. This is the aorta. This is the atrium. And only this is thickened. This is a posterior wall. This is not thickened. Posterior wall is not thickened. Only interventricular septum is thick. That is only very big in size. Sorry. So this is showing, you can see this is the IVS which is thickened. Then there is a SAM that is seen. SAM, I will tell you what is that. As I said, mitral valve gets sucked ahead anteriorly. So that is called as a systolic anterior motion. SAM, S-A-M, systolic anterior motion of the mitral valve. So that M mode you can see, normally this M is seen. This bump you can see. This is a 1M, this is a second M. This bump is normally not there. In a normal you and me, if you do this, you will not see this bump. So there is one more bump that is seen because the mitral valve is moved up. This is a mitral valve M mode. Okay. So that is the finding that you see. SAM is representative of hypertrophic cardiomyopathy. Then on Doppler, what we see, see this is a turbulence. Now this is the IVS, this is the mitral valve. So you can see there is a turbulence across the LVOT. That means there is an increased velocity. There is a resistance, there is a velocity is increased in the left ventricular outflow tract. So which gives you turbulence, and this is represented by gradient. This is a Doppler which shows there is an increased gradient. Normally this gradient is only this much, 10. And it is dynamic. You can see here it is dynamic. For this beat, the gradient is only this much. Whereas these 2-3 beats, it is little more. You understand? So it keeps on changing depending on the cardiac cycle length also. It can change depending on Valsalva maneuver also. If you do during 2D echo, it will change. So that this is a dragger shaped LVOT gradient that is seen in these patients. I hope you are you are understanding, no? Okay. Then there is something called as a transesophageal echocardiography. That means if you want to see the heart properly, one is you can see from outside. But when you see from outside, there is a bony cage outside. So bones cause little less visualization. Bones can hinder your finding. So you don't want bones. So how will you see? You go behind the heart. How will you go behind heart? Heart तो इधर है, उसके पीछे कैसे जाओगे? So you go through the mouth. You go through the mouth, you enter the esophagus. Esophagus lies behind the heart. So you go inside the esophagus, and from esophagus you do the 2D echo. So this is called as a transesophageal echocardiography. So we put in a probe which goes inside the esophagus through the mouth, and we visualize the heart from behind, and that will make you more findings. It will give you more findings, more clear picture of the heart, and you can see the echo. Now the most commonest thing that nowadays we do is a MRI, cardiac MRI. MRI gives you much better picture of this clinical condition. So I'm just going to show you some of the MR pictures. You can see this MRI. See, this is the thickened interventricular septum. Can you see this? Interventricular septum is thickened. Here, even this posterior wall is also thickened. So this HCM has got both IVS as well as posterior wall thickened here. This is the left atrium. Can you see? Left atrium, left ventricle, and this is the aorta. Blood is coming from here, going out from here. Okay? This is the MRI picture of the heart. This gives you much clear information on MRI. This is another cut section in MRI where you can see this is the left ventricle, this is the right ventricle. So this part is thickened. Can you see this? It's a thickened left ventricle septum that is seen. MRI will show you all SAM, LVOT obstruction, mid cavity obstruction, apical hypertrophy that is there, that can be also seen here. Now in this also you can see this image. Sorry. You can see here, this is the interventricular, this is a proper septal hypertrophy. This is the heart, this is the left atrium, this is left ventricle, and that is aorta. So you can see IVS is thickened. This is the posterior wall. This is not thickened. Okay, this part is very thin. Actually, this is papillary muscle. This is not the part of posterior wall. This is the papillary muscle. So IVS is thickened over here. Here also you can see in this cartoon, IVS is thickened. So this is how the MRI will help you. MRI will also help you to go into the details of these muscles. These muscles can be identified properly. You can delineate the fibrosis. If there is a fibro, that means as the disease progresses in HCM, the muscles are swollen, dilated, hypertrophied. By the age beyond the 40 years of age, these muscles start dying also, and they will cause fibrosis. They will cause a scar over there. So that will be delineated. In between, if you see a scar tissue, that can be seen by MRI, and that scar is responsible for VT in these patients, and VT also causes sudden cardiac death in these patients. So mid myocardial patchy and confluent areas of enhancement are seen due to the scar in these patients. So you can see here, this is the left ventricle, this is the thickened septum, and can you see this white shadow, this white? So this is a scar. Okay, as I said, when striae are seen, once you do more of bodybuilding, similar kind of striae are seen within the hypertrophied muscles over here. It helps you to prognosticate. That means if more scar is there, if the scar burden is more than 50% of the mass, full mass, if left ventricular mass is suppose 300 grams, and if you see that the scar is 45 grams, then it is significant scar. So this patient has a high risk of sudden cardiac death. Basically, risk stratification can be done by scarring. This patient can die suddenly because of the VT, arrhythmia, ventricular arrhythmia. He can have atrial fibrillation. So you need to treat this patient. To prevent sudden cardiac death, what we implant is a AICD, as I said. I think the further talks of treatment will cover all these things. So it helps you to prognosticate the patients of hypertrophic cardiomyopathy. This is comparison MRI findings in different diseases which mimic the hypertrophic cardiomyopathy. So you can see again one more cartoon showing again hypertrophy over here. Can you see this? Very thick hypertrophic septum here. Again I will play this for you. Can you see this IVS which is thickened, this IVS which is thickened here. So these are different images showing hypertrophic cardiomyopathy. This is one more image. See this IVS. This is RV. RV cavity has become so small. Can you see? This is LV cavity. This is IVS is thickened so big. It has become very big. Normally it has to be this size, this small size. Instead it is double, triple of the thickness. Okay. This is another cartoon showing IVS with scar in between. Can you see this white tissue? This is all scar. Okay, so this white tissue in between is a scar. This is also white tissue in between is a scar in the left ventricle. So this actually this patient has extensive fibrosis of 45%, more than 45%. So very significant scar. So this patient will have ventricular arrhythmia. If you have a scar, short circuit can occur anywhere. Current can flow around the scar and cause arrhythmias over there. So I think I will stop here. So these are the major investigations that you do, and I think risk stratification is being cover karte koni. I will just cover the risk stratification. So major risk factor is young age. Usually once you cross the adolescent age, the disease behavior changes. But sudden cardiac death is commonly seen in younger individuals. Non-sustained ventricular arrhythmias, if they are there, it is an independent predictor. That means they have higher risk of sudden cardiac death. LV wall thickness more than 30 millimeter. If it is more than 30 millimeter, it is called as a very high risk. Family history, the first degree relative family history of sudden cardiac death asil tar, history of syncope, associated left atrial enlargement, kiwa LV outflow tract obstruction, and blood pressure response abnormal. That means once you exercise, if the BP starts falling down, that is also abnormal BP response. Normally if you exercise, BP increases, but if obstruction is there, BP will fall down. So that is also a very high risk factor for hypertrophic cardiomyopathy. So these are the major things that I think as a paraclinical person you should know, or as a student of zoology I think you should know. So I think any questions you can ask me. This hypertrophic cardiomyopathy is still enigma. We still need to understand it. I think one of the arm of that is genetic analysis, I think, which you all guys are taking up. Clinical part we do take care related to the treatment part or diagnostic part of it. But I think genetic testing and how you can treat the genes so that you don't get it only, I think is a challenge. So I think there your role will probably come as a researcher or investigate student.
Hello sir,
yes.
First of all I would like to say very nice talk, and all the concepts are very clear. So I have just one question, like suppose we know all this diagnostic ECG and other advanced diagnostics, so these things are not available at home. So suppose can we get anything just by looking at the blood pressure pattern of any patient? But can blood pressure pattern tell anything about the HCM or any indication about the HCM?
Okay. Normally blood pressure is normal commonly in these individuals. Whenever you are at rest, there is no LVOT obstruction. So blood pressure is going to be normal. But when you exercise, as I said, when you exercise and if you measure a blood pressure, on exercise your blood pressure is supposed to rise usually. If it does not rise, Instead it falls down. That is an indicator. So falling of blood pressure with exercise is not a good finding. So that patient should undergo a test then. Okay?
So my question is there any geographical correlation with hypertrophic cardiomyopathy? What I mean to say is there any particular region in which their population is more susceptible to this disease?
Yeah. I think probably sir may answer these questions to you later, but there is some of the families are there, in some areas where the consanguineous marriages, it's an autosomal dominant disease. So if you have a consanguineous marriages occurring in some locality, you are likely to have more chances of hypertrophic cardiomyopathy. So that is why we say, you don't get married usually in the relations, so that you prevent spread of genetic diseases. That is a common thing. In India, if you ask me, most of the cases are more sporadic because incidence is not that high, or probably it may be underreported. That is also another thing, because we don't have any registry that commonly, I think probably in Pune, Varsha is the first one to go ahead and at least find out these cases with our help. And even we also took some efforts, and we reported our cases. Yeah, we do have these cases, and this is what, if I see 100 patients, I find one patient at least has hypertrophic cardiomyopathy. So I think that kind of research is still lacking with India. So regarding geographic spread or geographic distribution in India, I think it is unknown as far as my knowledge goes. There are small studies from south. I think Hyderabad University has got some studies being published regarding the incidence, but that is also, again, it is not a population survey. It is the index cases. The case comes to a clinician and then you diagnose. So it is not population based study. So in India there is no population based data that is available. Outside it is definitely there, and the incidence is about 1 in 500 overall in Caucasians population. That is usually the American and European studies that they show. There are some families known to have associated diseases that have been reported, but I think you have an answer for this.
There are some small, again, you answered mostly, but again, it's not like specific population. There is no specific or selective population that has very high number of hypertrophic. There is no such a population. It's mostly sporadic. But there are genetic variants that are very specific to certain population. For example, Indians, we have our own variants. Finland people, they have their own variant. Netherlands people, they have their own genetic. But it's like 50 generation, it keep on going. Like somebody got the mutation 50 generation ago and moving on, So those kind of studies are there. But it's not number of patients within one population. We don't have any. Yeah.
Any more questions?
Sir, can we decrease the thickness of that interventricular valve by using lasers? Laser use करके.
Yeah, I think that will be taken care in next lectures, how to treat this hypertrophic cardiomyopathy. There are various ways it can be treated. Laser, we have not used it, I haven't used it, but we can cut this septum. So you go open the heart, and whatever hypertrophied septum which is causing obstruction is just cut, called as a myectomy. Then there is something called as a alcohol septal ablation. That means you go find out the artery that supplies blood supply to this part of the septum, and we go ahead and inject the alcohol in that, absolute alcohol, so that that muscle becomes dead. So it's causing a heart attack in HCM patient, remember this. So that is one therapy that is available. and there is a radio frequency ablation available. So we ablate this by radio frequency ablation, whatever excess tissue which is protruding into the left ventricle. So these three things are available right now.
Whether this increase in thickness is related to more expression of myosin gene?
Whether this
Increase in thickness is related to expression of more myosin gene?
I think sir will be able to answer that. So this I have found no correlation as such, but I think let sir talk about this.
Aging is like nothing to do with myosin heavy chain. So humans, we have two different isoforms. One is alpha myosin heavy chain, another one is the beta myosin heavy chain. So before birth you have alpha, after birth you have the beta. But again, in the hypertrophic process, if you have a gene mutation in beta myosin heavy chain, you develop the disease. So there is not such a, there may be 1 or 2% changes, increase or decrease in alpha, but it's not an impact in aging.
I think Dr. Badani will cover all these things tomorrow, the penetrance.
I have a question on echocardiogram. So,
Yes.
for example, patients, they come, but baseline echo, there is no difference, right? But when they do stress exercise test, and then you do echo side by side, then you see there is a big difference. How the muscle relax or the diastolic dysfunction, you can clearly visualize. How do you explain this again? I mean, I'm trying to understand the disease prognosis.
Yeah,
Baseline, you don't have any difference compared to a normal person, you know. But when they do exercise stress test, and there is a difference.
You are talking about the hypertrophic cardiomyopathy
Yeah.
patient. So when you have hypertrophic, as I said, it is a dynamic process. So moment the left ventricular cavity reduces in size, the IVS, the septum becomes more swollen. If the LV cavity is small, shrinks down, the muscles in that area, septal area, start coming together as the heart rate goes down. And that is how the LVOT obstruction starts coming in. So if you do echo at that time, you will find there is an obstruction at higher heart rate. So we usually give isoprenaline or amyl nitrate to precipitate these kind of events, and you can do exercise, but by the time one lies down, I think heart rate settles down, so you can't really actually assess this. So drugs is a better thing to go ahead and find out this. So inotropy can be increased by drugs, and you can diagnose these situations. And this is the mechanism is this.
Normal diagnostic test you normally recommend, or you don't? It's kind of
we don't usually recommend to go ahead for every individual unless there is a strong, strong history of syncope in this patient, and baseline echo has nothing. There is no LVOT obstruction. You find no gradient. Then yes, we do provocative tests sometimes. But exercise test, and this gives you very good information most of the times.
In your experience, have you seen any patients within 10 years of age or 20 years of age, very, very young?
I have seen below 10 years also, not too common, but yes, 10 years, below 10 years, 1 or 2 patients we have seen. It is very difficult to diagnose in them because septum is not very thick in them. It is yet to hypertrophy significantly. So it just looks like an athletic heart. So if you have a strong family history, suppose father has it, so this patient's father had hypertrophic cardiomyopathy. So I did know that there is a clue that this may be hypertrophic, this is not athlete. And now moment she has become now 18 or 20 now, so I see that her IVS has started getting thickened significantly. So she is carrying that gene with her, it means.
Also, have you seen in your clinical experience the clinical outcome difference between male and female, like women and men?
Yes, males have got little, incidence of sudden cardiac death is more with males compared to females. Females tend to have more of, once they survive middle age, that is 35 to 40 years of age, they have progressive heart failure. That means muscles getting weaker or the congestive heart failure predominates in them. rather than sudden cardiac death. Obviously, because of the adrenergic drive, and these are the different factors which are responsible for sudden cardiac death more in males. So males have got little more aggressive course compared to females, if you see, regarding sudden cardiac death, whereas heart failure is more in females.
Any more question?
Sir, are there any symptoms of this disease during the fetal stages of humans?
Fetal stages, usually nothing, because it's in the womb. Fetals cannot, you can only, if it is there, you can diagnose it. You will know that the fetus has septum which is thick. If it is there at birth itself, then you can diagnose that yes, there is a probably hypertrophic cardiomyopathy in this patient. But in womb, you don't get any symptoms.
Does it cause any complexions during fetal stages?
There is any cause?
Complexions.
Complications.
Sorry, complications.
Not that I have heard of any arrhythmia in fetus. I have not heard, and we really need to understand that. In that case, I have not seen any fetus being diagnosed. For that matter, I will tell you frankly that I have not seen any fetus being diagnosed. I have seen one fetal specimen when I was student of hypertrophic cardiomyopathy, but that baby was again had a SCD. Baby was dead, and that is why baby was dissected to find out what is the cause. But I had not done that. It was, I think, Dr. Deshpande from GS Medical who had done that autopsy, and I had seen that specimen. That is the only experience I have about fetus in hypertrophic cardiomyopathy.
Any question?
But it's a good point to elicit a new study. If you are really thinking about it, you ask Varsha and start with some new project to find out hypertrophic cardiomyopathy in fetus. Incidence of hypertrophic cardiomyopathy in fetal population can be found out definitely, and it's a good project, I will tell you. So I think you can coordinate with Varsha and go for a study rather. That's a better thing. So any students who are coming can take up that kind of topic, and really in our population, though we don't know, and I have not read any reports, so we'll have to go through that.
Sir, how does food diet influence the progression of HCA?
Not that I know any diet doesn't change, because it's a genetic problem which causes disarray. So diet will only change associated coronary artery disease incidence in this patient, but not per se it will affect to cardiomyopathy that I know of. There is no literature regarding that. There is no finding like that.
Will it affect the progression of the disease once it happens?
Sorry?
Once it happens, will it affect the progression of the disease?
Yeah, that's what. There is nothing, no literature, and we don't have any experience regarding that.
I have one comment. Again, in hypertrophic cardiomyopathy, it's not only in humans, but also in animals. For example, Maine Coon cats, dogs, even horses, they all develop hypertrophic cardiomyopathy. It's a pure genetic heart disease. By diagnosis, you have to exclude hypertension, diabetic, anything. They exclude it, and they define it's only a familial disease.
That's a good thing.
No more questions, I guess. Thank you so much, sir, for such insightful talk, because you have really explained very nicely with such illustrations. With this, I conclude today's session, and tomorrow we will meet again for day 2 at same time 9 a.m. So thank you everyone and have a wonderful day.
One more thing.
Thank you.
So I would like to tell you that tomorrow tutorial session is there. So whatever sir has taught you now, you have to prepare that very well. Read about the SCM and make a small presentation of 5 minutes on SCM. And the few medical terminologies will also be asked in the tutorial. So whatever sir has taught you today, please read about those. Okay? Thank you.
Thank you all of you.